Hi, good morning and afternoon, everyone. I think we can make a start. So I'm standing in as chair for the webinar today. The usual chair, Edward Katika, is presenting, giving one of the talks. So I'd just like to welcome you all to the 5th webinar of the series of the ECSA Global Health Economics webinar series. I'm Paul Revel, a professor from the University of York. So the webinar series was established as part of the ECSA Health Economics Community Practice about a year ago with the support of the Tansy Lonze programme. It's a platform that brings together health economists and planners, mainly from the ECSA member countries and supporting countries, to interact and exchange knowledge and experience on health economics related topics. So these global health economics webinars are part of the knowledge exchange and continuous learning for members of the community practice and others interested in enhancing their understanding and capability in health economics. And in the webinars, we invite experts in various areas of health economics and related fields to share knowledge and experience in topics that are of interest to the community of practice. So the topic for today's webinar is ethics and equity. So health systems have two primary objectives. Firstly, to improve the health of the population, and secondly, to reduce inequalities in health and in access to healthcare. You can characterise these two objectives as the first being related to health system efficiency and the second being related to equity. And the webinars to date have focused primarily on efficiency considerations. Equity concerns run through all decisions in terms of the formation, functioning and financing of healthcare systems, and hence why today's topic is so important. And the issues of equity really bring together economic considerations, but also rely upon notions of ethics. So in today's webinar, we have two speakers. The first talk will be by Professor Joseph Mfuto-Benga, who is a director and professor of health systems, is the director of the Health Systems and Policy Department of the School of Public Health at the College of Medicine, University of Malawi. Professor Mfuto-Benga is a professor of bioethics, chair of the University of Malawi, and dean of the School of Public Health and Family Medicine. And he's a globally respected international research, ethics, bioethics and governance scholar, an educator and behavioural studies scientist. He is also the Malawi PI of the Tansy Lonze programme and the director of the Centre for Bioethics in Southern and East Africa. And he also directs the Centre of Excellence and Governance and the Health Economics and Policy Unit in Malawi. Professor Mfuto-Benga served as a member of the Safety Monitoring Board for the US National Institute of Health Division of AIDS and for 5 years, and has served as a reviewer for the US Academy of Sciences and Institute of Medicine. Professor Mfuto-Benga's talk is entitled Proposing a Leadership, Ethics, Governance and Systems Framework, which is termed LEGS, for ethical, equitable and efficient allocation of healthcare resources in Africa. So following Professor Mfuto-Benga's talk, we'll have also a talk by Edward Katika about economic approaches to dealing with issues of ethics and equity. So hopefully the two talks will be very complementary upon one another. So if I could hand over to Professor Mfuto-Benga. Thank you.
Can you see?
Yes, clearly, thank you.
Okay. Okay, thank you very much. My topic is proposing your legs framework for ethical, equitable, and efficient allocation. Before we start, we understand it's very important just to know the definition of the systems. WHO define health system, all organizations, all institutions, all resources that are devoted to producing health actions. So this definition includes different types of system: formal, informal, intersectoral system, public, and non-profit. So a good system delivers effective, appropriate, safe, and quality health care. And these are the building blocks, which are service delivery, workforce, information, procurement, which is medical products, financing, leadership, and governance. And according to WHO framework, this is geared at producing access, coverage, quality, and safety. So the problem statement which I have is that WHO building blocks for health system strengthening is working well in advanced countries with strong governance, but we have found that they're not working well in the developing countries with weak governance system. And one of the challenges is health inequity, and I would define health inequity is, according to the WHO, is any preventable differences in access, so preventable difference in access to health care. So this is was a study which I did, or it was a desk review which I did for low-income countries like Malawi, and I looked at equity. The results of the review is that the barriers and the enabler of health system in Africa and low-income countries identify 4 frequent themes: leadership, ethics, governance, and system as the main determinants affecting healthcare delivery in Malawi and Africa. The ranking in LEX is based on frequencies. So the leadership of the first, when you were looking, and the assessment of who building block showed that there's no ethics as a building block. They talk of health working force as a human building block governance. So they talk about health working force, but they don't talk about ethics. Even though equitable access is one of the WHO outcome, the WHO outcome, but ethics is not explicit in the building block. So equity is an ethical concept. So leadership and stewardship and governance is assumed as one building block. So again, I'm coming to show you the building blocks. Discussion. So the WHO acknowledged that inefficient use of funds could be due to corruption, and it is insufficient to effect change when ethics and equity is treated as essential and implied, because one knows that lack of professional ethics and integrity, like corruption, can disorganize, derail, undermine, and damage the design, operation of any health system, and this is one of the main sources of inequity. So corruption affects equity. Lack of professionalism affects equity. So ethics, being an individual and collective organization issue, should not be reduced to solely health workforce. So I've got citation. So I'll continue. Professional ethics and integrity at various levels is needed. Procurement, clinical work, human resource, etc. Surveys shows that in both low income and high income countries, corruption is still prevalent. In Malawi, for example, in Africa, some say that even 30% of national budget is rot through corruption. And this could affect lack of integrity, and therefore leadership can affect equity and efficiency. So this is what legs come. So to your left, you see that these are the 6 building blocks. What I've done is the first building block, as I've expanded to become 3, what I call leadership, ethical engagement, and governance. And the other building blocks from 2 to 6 are being squeezed to a system. So all those are called elements in a system. But also there's another element which is auxiliary system. So those are called self-delivery workforce, self-information, access to research for medicine, financing are called core elements. Then there's another one, seventh, which I call it auxiliary elements. These are social determinants of health, poverty, gender, environment, etc. So you need leadership, ethics, and governance to run a system. So you need leadership, ethics, and governance to run efficient, equitable, sustainable system. So the base of a system, the foundation of a system is leadership, ethics, and governance. Without that, a system cannot run. There are two types of system: the law of ethical leadership in ensuring equitable resource allocation and use of community-based society. So there's community-based societies and system-based society. In community-based society, the law of a leader matters. In a community-based society like Malawi, a leader is a system. So if a leader is a system and is not ethical, it can be dangerous. It's different from system-based society where social contract matters more than leadership. So social compliance is regulated many of social contracts, rule of law, strong system, respect of fear of the law. So in the weaker system, control can be compensated by inner control, strong controls, which is ethical leadership. Many African countries are community-based society. However, the neglect of moral capital has not been fully compensated by strong rule of law. So in the West, perhaps they may lose the internal controls, ethics, but they have compensated that with strong rule of law. So you can see now the ranking in Africa. Leadership ethics comes first. If you ask people, they say leadership matters. When you look at system-based society, system matters more. Governance and social contract matters more than leadership. Therefore, there are four factors that do influence quality and equitable healthcare. So leadership, ethics, governance, system matters. One needs a leg, leadership, ethics, and governance to run equitable and equality healthcare. However, one needs legs, leadership, ethics, governance, and system to implement health policy into best practice. So the association between leadership and the equity and the efficiency. Good leadership demands quality and equity. Good leadership monitors quality and equity. Martin Luther King session says, the price of good men pay for indifference to public affairs is to be ruled by evil men. To ensure equitable allocation and utilization require effective and ethical leadership. Alejo Salzon said, the offer of moral capital, so it says, moral capital for leaders while virtue matter. No amount of human, intellectual, or social capital could make up for lack of moral capital among workers for the long term of success of enterprise. So if we want equity, we should do in a community-based society like Africa, you need ethical leadership which can influence equity. So I'm finalizing now. Two slides many. Ethical association between ethics, equity, efficiency, and economics. Ethical economics is about honesty, fair, equitable allocation and use of resources, balancing needs and merit, social protection and human development, the individual benefit with common public benefit or common good, bearing in mind intergeneration, intersector solidarity, and sustainable use of resources. According to ethics, to have efficiency is to maximize benefit to maximum number of people at minimum cost, risk, harm, and to do so, it is right and good to do things to aim at rightness and goodness of an action, to balance long term with short term. So Jonathan Wright argued that economic right relies on three interrelated ethical systems. So outcome-based, that's utility value, duty and rule-based, deontology, and virtue-based goodwill. Without goodwill and good faith, the other outcome can be affected. So I'll just show you the ethical principle of equity. Again, I say it's first is the beneficence, maximizing benefits, maximum number of people. Global lack of equity is potentially biggest human challenge and social risk. Non-maleficence. Lack of equity can bring about social harm through riots and unless equity deficiency has negative benefit cost ratios. It's cost right. And the lack of equity hinders actually economic development. This per person, lack of equity, that you are not respecting human dignity. And justice is to share, to ensure equality and equity is to be fair. So when you want to have equity is part of fairness. So John Laws, this is my final two slides because of time. John Laws define equity as treating those who are equally and treating those who are unequally. In the health system, WHO talks about vertical and horizontal equity. So it means treating those who are equally is unfair. However, all human beings deserve equal opportunity, equal dignity, and equal political liberty and human rights, and can never be traded. So any unequal treatment of those that not equal should be to the benefit of vulnerable. So John Law's framework on equal resource allocation talks about a veil of ignorance. That if you don't know, everybody, both anyone in the world, if he didn't know what it would be, he would have made decision which targeting the vulnerable. If everybody thought that it would be vulnerable, it is because we do not have that. So a conclusion, because of time, I will just want to conclude. All health institutions require a leg to run ethical, equitable, and efficient health system. To build and run equitable and predictable system, organization needs to inquire that to ensure that there is a strong foundation of leadership, ethics, and governance. These are the main three necessary preceding foundation building blocks for building equitable, resilient health system. A leg without a system cannot have impact and cannot achieve its intended outcome because a system is a means to achieve the goals. This review has shown that all organizations need four legs in order to translate knowledge, skills, policy evidence into the best practice for positive results of equity. So legs matters. Legs framework is simple and easy to remember and use. Thank you.
Thank you very much, Joseph. Really interesting. So if you could possibly unshare your screen, you can move on to the second talk for today. So I was by Edward Katika, who is a health systems development expert with over 20 years experience in health management, planning and economics. He's currently Director of Programs at the East, Central and Southern African Health Community. He's responsible for the overall implementation of programs in the organisation, focusing on 21 countries in Eastern and Southern Africa, including 9 ECSA member countries. He previously worked as manager for the Health Systems Development Programme in the same organisation. Before joining ECSA, he worked as a health planner for the Ministry of Health in Malawi, rising to become the Deputy Director of the Planning Department. So Edward has expertise in using a range of approaches and tools to analyse and diagnose health systems problems and recommending context-specific actions for their strengthening. He has provided technical assistance to the ECSA member countries, mainly in the areas of healthcare financing and human resources for health. And through his involvement with the Network on Equity in Health in Southern Africa, Equinet, he has participated in health equity analysis assignments in Malawi and in the wider region. So Mr. Katika's talk is incorporating concerns for equity into health resource allocation decisions. So over to you. Thanks, Edward.
Thank you very much, Paul. Can you hear me and can you see my screen?
We can hear you, but if you could put the screen on view, we can also see the sidebars, the notes sections. Maybe if you just
Correct.
click the.
Are you able to see it?
No, I'm not. Not
maybe.
Sure what's happened.
Okay, let me try it again. Let me do it again because
There we go. We can see that now. Thanks, Edward.
Oh, you can see
perfect.
It. Okay.
That's good.
All
Thank
right.
you.
Yeah. So thank you very much, Paul, for that introduction. I normally chair these webinars and introduce people, but today the roles are reversed. So I have been introduced, which I think is very good. I now have an idea of how it feels to be introduced. So as the chair said, my talk is on incorporating equity concerns into health resource allocation. Oh, it's not moving. All right. Yeah, I think as we are all probably aware, we are all aware how important the issue of health equity is. The chair mentioned in the introduction that reducing inequality is one of the health system objectives. And indeed, health equity is recognized by governments and international organizations, as well as regional organizations, as an important health policy objective. If you go back to the Alma-Ata Declaration on Primary Health Care, equity was one of the principles that came out explicitly, and it has been throughout, even with the recommitment at Astana. Equity still stands as an important policy objective. When you talk of universal health coverage, equity is also a very important principle in there. Even sustainable development goals generally, we have one that talks about reducing equity, rather reducing inequalities between and within countries. So there's recognition by the development community that equity is a very important policy objective. Now, over the years, a wealth of techniques have been developed, to measure and inform policymakers as well as a way of promoting health equity. So what I'm going to do in this presentation is to share and show how just some of the tools and approaches that have been developed can help address resource allocation questions that people in various countries may have, so that resource allocation does incorporate aspects of equity. When we talk of inequality, we are referring to the differences in healthcare access and healthcare outcomes. Those are the differences that are seen to be unfair and unavoidable and can be minimized through policy intervention. So I am going to give an overview of some techniques that can help to address the key health equity questions that decision makers in countries, the policy makers, usually ask, and they would like to have information to understand more about these issues, so that they can actually address those questions with more informed, in a more informed manner. The questions that typically the policy makers or decision makers have in countries are: what is the current level of inequity in health? What is the magnitude of inequity? They would want to understand this so that they best address it. And then about government expenditure. Who benefits from the government expenditure? More specifically, does the expenditure benefit the worst of those that need the resources most? And then how can government expenditure more effectively promote equity? These are the questions that decision makers every now and then ask themselves, and they would like to provide answers to. So in terms of measuring health equity, there are studies that are conducted in various parts of the world, and they use various methodologies. And these analyze data mainly on healthcare utilization, on health costs, but also health outcomes. Now, as inequality is about unfair differences, equity is normally defined in terms of the unfairness between social groups, and analysis require information on the variables such as age, sex, income, education level, and area of residence, such that one is able to assess if the differences are based on such variables, and if they are unfair, they should be addressed. So the level of inequality can be estimated from data using a range of metrics that vary in their level of sophistication. There are some that are relatively easy to calculate and interpret, and yet there are others that are also more sophisticated and require more complicated methodologies to generate. So here I'll be giving an overview of just some of them, about 3 or 4 of them, but I will not go into the details of the methods. I'll just give an overview and how these can actually be used by decision makers to address the questions that they normally encounter relating to equity. So first question that is usually asked by decision makers: what is the current level of inequality in health? Now, supposing we have data from a population sample on healthcare, and it's disaggregated by age, sex, and household assets. Most countries that conduct demographic and health surveys do have this kind of data on healthcare utilization, and it's disaggregated usually by, as described, by age, sex, and household assets. If we have this data and we want to summarize equity, we want to do some equity analysis, one way, a very simple way of summarizing this, first, we would want to create subgroups from that population, mainly households. We want to create subgroups or wealth quintiles. These are subgroups that are defined by household assets, showing the wealth of the households. So normally, most countries will do a disaggregation. They'll create 5 groups known as quintiles, where the first group are the least wealthy households, the least 20%. And then you have the next 20%, all the way up to the top, the wealthiest 20% of the households in that sample. So you create those wealth quintiles, and then to summarize equity, you just take an average utilization level in those subgroups. In each of those wealth quintiles, you take the average utilization level, and then you compare the differences in utilization of healthcare in terms of average visits between the lowest quintile, the least wealthy, and the highest wealth groups, and you see what the difference is like. So you may observe as an example that there is a difference, also known as an average gap, in the number of visits between those 2 groups. To say, you may observe that there are more visits in the higher income groups, the wealthiest group, and maybe the difference is 1.6. What that means is that the wealthiest group is making 1.6 more visits to health facilities than the poorest group. And that is some kind of measure of inequity in terms of utilization of healthcare, where more visits are done by the people, the group, the households that are wealthier than the poor. So that is a very simple way of assessing, summarizing equity in terms of utilization. But of course, simple as it may be, it may have its own limitations. That kind of analysis will ignore information about the middle groups, the three middle groups, because here we are just comparing the two extremes, the poorest households, 20%, and the wealthiest. And there's no information about the other groups that are in between. So an alternative approach is to include average utilization of everyone, all the groups that are in the sample, so that we have a picture of everyone, what is happening with everyone in that sample across all the 5 wealth quintiles. So that can be done using a scatter diagram where you just plot average utilization in a scatter diagram and plot a line of best fit through that data. With that, you will have a visual display and have a clearer picture of the relationship between the utilization and a wealth quintile. So you will see that the relationship, if there is an increase or a decrease in utilization as you move from the least wealthy households moving towards the wealthy households, you will see what the relationship is in terms of utilization levels. But that can also assist you in generating relevant matrices. Here is an example. What we have on the right-hand side of the slide is an example of what I have just talked about, a scatter plot that has a line of best fit fitted into the data there. This is showing a relationship between neonatal mortality rates per 1,000 live births and the wealth quintiles of a certain country. So we are showing here the relationship between neonatal mortality and the households. So here we can see that the line of best fit is downward sloping, showing that as you move, neonatal mortality tends to be higher in the wealth quintiles that are the poorest, the first quintile. These are the poorest 20% of households. And as you move towards the wealthier households, the mortality rates, the neonatal mortality rates tend to be reducing. So that is clearly inequality. It shows us that there is inequality here, where the wealthier households tend to have lower rates of neonatal mortality rates. So this is an example of something that one can use to measure or to demonstrate inequality in a health system. And out of this, one can also come up with matrices which can give decision makers or policy makers the extent of the inequality. And these are examples that we have on the left there. We have the slope index of inequality. That is basically the slope of that graph that has been fitted there, which is -27. And the way to interpret that to a decision maker to show the current level of inequality is to say, as you move from the highest, the wealthiest households towards the poorest households, you tend to get 27 additional deaths per 1,000. So there's an increase of 27 mortality deaths, neonatal deaths, as you move from the wealthier households, the wealthiest households, towards the least wealthy, the poorest. That gives an extent of current level of inequality. Again, from here, one can calculate relative index of inequality, where the results can be presented as described there, where you would say deaths per 1,000 births at the bottom end are 60% higher than at the top. So there are 60% higher deaths in the lowest 20% of households, so compared to the highest, the wealthiest households. That gives the extent of inequality in terms of neonatal mortality rates. So that is an example of how one can show inequality and measure and provide some matrices to decision makers. Another way of demonstrating the level of inequality is by use of Lorenz curves or concentration curves. And here I'm also just giving an example of what the concentration curve looks like and to demonstrate the extent of inequality in health. So what we have here, and again, this is based on real data, we are comparing the cumulative percentage of health insurance coverage and the cumulative population as ranked by wealth. Again, we are talking about the quintiles, the 5 wealth groups in a country. And I think this is an example that is coming from Kenya. Now, when you have a concentration curve like this, we have the straight diagonal line. That is a line that shows equality. When you're on that line, there's equality there. So you will see that if you go to the 20% point, if you look at the 20% of the population, it will account for 20% of insurance coverage. You go to 40% population, accounts for 40% of insurance coverage. So there is equality when you're on that line. Now, the curves below that, which is now the actual situation, will show you the extent of the inequality, because the further away you move from that diagonal straight line, the bigger the inequality. So you will see that greenish line, for example, that if you go to the population 20% point, you see that 20% of the population has less than 10% actually. Less than 10%, account for less than 10% of the insurance coverage. So that shows you that there is inequality there. The population in the lowest households account for less than 20%. They are 20%, they account for 20% of the population, but they account cumulatively less than 20% coverage for insurance. So that will show to demonstrate the extent of inequality in a health system. Out of this, one can also come up with metrics, and they come up with concentration indices, which will show quantitatively the extent of inequality. And these will normally range from 1 to -1, where 0 is the equality, but then as you move towards 1 or -1, it shows you the extent of the inequality. The next question, policy question, does government health expenditure benefit the worse off, or who benefits from government expenditure? Now, to do this, the technique that is normally used is the benefit incidence analysis. This is used to measure inequalities in the distribution of benefits from government health expenditure. And benefits refer to the financial value of services used, that is calculated by multiplying the number of times that each service is utilized by its unit cost. Of course, when you do this, if there are user fees, you take off the portion where people pay user fees, or if there is insurance, because here we are only interested in the government expenditure. So we look at the financial value of the services used, but that is financed from government expenditure. An example of the results from benefit incidence analysis are shown on the diagram on the right side of the slide. Here again, we are talking about wealth quintiles, where the bottom are the poorest 20%, and at the top you have the wealthiest 20% of the households in a health system. So on the left side are the total benefits. So according to the results here, you see that the poorest 20% of the households benefit about 18% from government expenditure. And the wealthiest 20% benefit about 19%. Now compare that with the total needs. If you look at the total health needs of the poorest 20% of the population, they account for about nearly 23% of the total health needs in that health system. Yet that group only benefits about 18% of total benefits from government expenditure. So there's a discrepancy there. The needs are 23%, but they are only benefiting 18%. Yet if you go to the wealthiest households, the 20%, their needs are only 15.7%, but they are benefiting 19% of the government expenditure. And the same can be said for the other wealth groups, where you see that there's a difference. The needs are not really aligned to the benefits in each of those subgroups. So you actually see that there is the inequity in terms of benefiting from government expenditure. This is something that can also be shown to decision makers to show inequity in terms of benefiting from government expenditure. Now, of course, looking at those the differences in benefiting from government expenditure, can government expenditures promote equity? And if so, how? Most countries have tended to address this, have tended to promote the equity of government expenditures through resource allocation formulas. And in doing this, the allocation formulas are done in such a way that there are variables, different variables that show all kinds of needs, things like population, age and sex, health needs, and service costs. And then weights are assigned here, are assigned to each of these variables. And with this is used those formulas are used to allocate resources to various geographical regions in a country, such that regions that have similar health needs are provided with the same resources. So that way you are promoting horizontal equity. And regions that have greater needs than others are provided with more resources than those the regions that have lesser needs. Again, thereby you're promoting vertical equity. So resource allocation formulas, if they have the right variables that reflect the varied needs, can indeed be used to promote equity in government expenditures. So in summary, health equity is a key goal in the global health policy agenda, and it's also recognized by governments and the international organizations. And health resources can be allocated in ways that can improve equity. And there are quantitative techniques that can provide evidence on the existing inequalities and the regional resource allocations. So to conclude, let me just acknowledge that what I have presented is mainly drawn from a report that I co-authored with some colleagues from the University of York Center for Health Economics. The people are listed there. This is the research paper number 160, which is available on the University of York Center for Health Economics website. So with that, I thank you for your attention.
Thank you very much, Edward, for an excellent presentation. So two very clear and excellent talks there. I wonder, Steph, if we could bring everyone into the main room for the Q&A discussion. So there are two means to ask questions or join the discussion. Really want this to be a discussion as well. You can either use the Q&A box, or I'd encourage you also to use the raise hand feature at the bottom of the screen to ask questions. So I encourage any questions now if you have them. See one hand. I wonder if I could maybe begin with a question for Joseph. So Joseph, you spoke very, very compellingly about the need for leadership and ethics in leadership-based systems. Just also trying to kind of draw the links between your talk and Edward's. and speaking as an economist, we're often interested in evaluating interventions which have effects, beneficial effects. Are there any interventions which come to mind which can help in strengthening leadership and ethics in particularly government systems?
Yes, so I'm saying that in the community-based, there's a system-based society and community-based society. Community-based society, a leader matters. But whether you've got a bad leader or a good leader, but their impact matters more than in the system-based society. So, lucky enough, I lived in both. I know, understand. In the system-based society, is a social contract what matters, the rule of law, and even the leader himself is under the law. In community-based societies, many of them, a leader is a system. And therefore, they need to have ethical leadership matters. So interventions is that if we want to have equity, and when we're talking about economics, we should not, in the community-based society like ours, we need here to also incorporate the concept of ethics, of professionalism, of ethical decision-making. Because allocation, resource equity is an ethical concept, and therefore we cannot think equitably when we are not ethical. So a person who is unethical will not think of another person, will only think about himself. So resource allocation, if it is not, I'm saying this because in a community-based society, a leader can set agenda, can set quicker agenda. And that's why in our context in Malawi, for example, a good leader can change things so quickly, like in Rwanda. A bad leader can destroy things quickly. Things which can take so long in the system-based society to make decisions. In a community-based society systems, a leader can actually influence more change, a faster change of anything, either negative or positive. So that's why I'm saying we need to, when we are doing interventions, any other intervention, there's a need to train people's in ethical leadership. Ethics should be part of the intervention. Governance should be part of the intervention. So intervention in the mean training, evaluation. When we are doing evaluation, sometimes we're monitoring and evaluation, we do also ignore values. We ignore values in people in their strategic plans. Many companies, many organizations, they put values. But when they're looking at outcome and they don't evaluate whether the values which they have put on strategic plan are being lived, are being practiced, and to look at the discrepancy of values between the normative what people have said and the actual values on the ground. So this is what I wanted to say.
Great, thank you, Joseph. It's very clear. We have maybe when you ask questions, if I can also ask you to introduce yourself. So we have a question from Dr. Juliet Nabyonga.
Thank you, Paul. I'm Juliet Nabyonga. I work for the World Health Organization based at the Africa Regional Office. And I would like to thank the two presenters for very good presentations. And I have a question for each of them. I want to start with Professor Joseph. My question refers to the leader being a system. So in that model, where is the room for consultative processes, which is actually a very good component of good leadership? Where is room for the consultative and participatory processes, and also in democratic processes, because you said the leader can change. Then what is the role of institutions? What's the role of, where is room for processes? And are the two systems distinct? That do they coexist? Do you see a model whether they work together, the community system and the other you call the system? Is it either or what we should aspire to have is a good balance of these two models? Then my other question goes to Edward. Again, Edward, thank you so much. And now I will speak as a health economist, but also I'll speak as a policymaker. I think the challenge we've had in this equity analysis, especially, is we are stuck in the quantitative approaches. All the time we talk of socioeconomic categories, sex and gender, and that's why policymakers are failing to address the problem. Because when you look at population-based surveys, 5 years apart, 15 years apart, the findings are the same. We are failing to tackle inequalities. Now, I think we need to take our evidence generation to another level, perhaps to look at mixed methods. We have the quantitative approaches that are telling us that there's a problem in the lowest socioeconomic category, but then how do we address it? And I think that's why policymakers need guidance, they need information, more refined data to address the problem. So do we see a blend of these methods? I think generating evidence is just part of the solution, but we need to take it to implementation for it to have impact. Thank you so much.
Thank you, Juliet. Joseph, would you like to begin?
Yeah, thank you for a good question. A leader is a system in a community-based society, but that means that a leader it just show how, if you rank the 4 pillars of implementation: leadership, ethics, governance, and system. In the community-based society, leadership comes first. When we ask people, in other countries, for example, I remember when I was in Germany, people didn't even know the name of the president. They couldn't remember Mandela in the class. I asked them, do you know the president of South Africa at that time? They say, oh, Mandela. Then I asked, what is the name of the president of Germany? They couldn't name. So it just showed that, but when we come to Africa, you ask a class to say, can you name the name of your president? You find everybody knows. So what I want to say is, in the community-based systems, a leader matters, whether it's good or bad, but the impact is more than in the community-based society. But that means that that's why a leader, I said there are 3 foundation pillars: leadership, ethics, and governance. These are interconnected because you need a link, you need leadership, ethics, and governance to run a system. Systems are 2 types of systems: they're informal and formal. Informal ones are community-based systems. But in the community-based society, a leader can actually have 2 parallel systems. You can have a police, and you can have also his own militias. You can have a formal system, but decision can be made in his own relationship networks. So what I'm saying is, there's advantages and disadvantages, but in Africa, leadership is not a game. To have a good leader matters. In other countries, perhaps it's politics, but here, when we're talking about a leader, we're talking about death and life, because they can actually undermine the system. A good leader will respect the system. A good leader will create a system and respect it and promote it. But a bad leader may even ignore the system. That's why I just wanted to yeah. I don't know what I've...
So just isn't what Julie writes, isn't that the right information? If you're within any particular country, the leader is whoever the leader is, it's a given, and the question of what can be done to improve governance and decision making, it isn't a huge part of the answer. Participatory approaches to governance, strengthening civil society, community representation in decision making processes, isn't that the implication of the community-based system that you set out?
Yeah, yes. So so when the advantage of, that's what I'm saying, the advantage of the community-based system is that if you mobilize the community, they can actually, it's not a system which will check the reader. It is a community which will check the reader. So that's why in the community-based system, it's not the system which will check the reader, because the reader can change the laws, can even ignore the leader may even ignore, can have selective justice. He can have the same law applied to some and some not. That's why I'm saying I like what that contribution, that community-based system, if they are independent from the leader, can actually become a kind of a check balance to the leader, but also they can help the leader who is good to achieve his own to use a system of community-based system and the informal system and formal system to achieve national interests. Results. Yeah. I don't know if I'm clear on that. It's coming. What I just wanted to underline.
Thanks, Joseph. I'm aware of time. I'll need to pass to Edward. Maybe Edward, if you could respond to Juliet's second question. Sorry, Joseph. I'm just looking at the time and trying to.
Yes.
Edward,
yes.
Like to respond to
Yeah, thank you very much, Juliet, for that question. I think you are raising a very important point here. We have all these methods, quantitative and all that, but maybe they haven't had much impact, policy impact. Yes, maybe it's time that we thought very carefully about the packaging of these results. I would not dismiss the methods outright because they have not had impact. They are still very important. They provide very useful information. But perhaps what we do sometimes as economists, and I'm glad you're also one, I'm sure you know this, sometimes when we do this quantitative analysis, we always assume that the policymaker or the person that we are presenting to understands these numbers and all that, and we don't interpret them properly. So I think we lose them that way. So what I'm saying is, I agree with you. We have to find a way of packaging these the results from the quantitative analysis in a very user-friendly manner, knowing that the person that will be communicating to the decision maker may not be coming from an economics background or a quantitative background where they can appreciate these numbers. And indeed, yes, using mixed methods where we also use other, could be qualitative and others, packaging this information so that the policymakers understand, they get the picture more clearly. I think with that, we should be able to make some impact when we make this equity analysis. So yes, in a way, I agree with you that we continue with the quantitative methods, but perhaps supplement this with the other methods as well, so that this becomes more user-friendly to the policymakers. Thank you.
Thank you, Edward. So where we've at the end of the hour, but just want to remain open for a couple of minutes to see if there are further questions or points from discussion, particularly also for participants to bring their own experiences into the discussion measures which have either proved effective or for some reason ineffective in the countries in which you live and work in respect of equity. Please feel free to highlight those. It'd be really interesting to hear their applied case. I'll just give thank you. A question from Linda Sander. If you'd like to introduce yourself also, Linda.
Thank you. I'm Linda Sander, I'm a health economist with the Malawi Liverpool Trust and a PhD student with the London School of Hygiene. On issues like on equity measures such as benefit incidence analysis, just as part of my PhD, one of the consensus has been the data needs. Some of those methods just require too much data, and when you're thinking about policymakers, and what they need to make decisions. I think it's important that we just think of ways that we can help with methods that are that don't require too much data if we want to help the policy decision making. Thank you.
Thank you, Linda. It's a really good, a good point. Edward, do you have any reflections on that?
Well, yeah, I think just to agree with the speaker that whatever we are doing here, when you're doing this analysis, data consideration, that data I think should be taken into consideration. I know that yes, when you're talking about data, in most countries in this part of the world, I know that the availability or even the quality of data is also an issue. But even when you have data, sometimes, yes, you do not want to overwhelm policymakers with too much data. And I think this is the point that I was making earlier, that sometimes you need to find a way of presenting your results in a user-friendly manner to the policymaker, knowing that maybe policymakers may not be coming from a quantitative background. So indeed, where you have too much data, maybe there has to be a way of sifting and giving them something that is, they can easily assimilate and be able to use for their own decisions. Thank you.
Thank you, Edward. And we have a question from Sally Lake. If you'd also like to introduce yourself, Sally.
Thank you very much, Paul, and thank you very much for the two very interesting presentations. My name's Sally Lake. I'm a health economist, most recently working in Tanzania, but based in the UK for obvious reasons at the moment. I just wanted to respond to Paul's request for some experience actually implementing those, and to just mention a couple of things. I've worked on resource allocation formulae in a number of countries within Africa, and the data is obviously an issue, data availability, data quality, but creating a clear understanding of the data, as has already been mentioned, is very important. What we found a lot in Tanzania, because the formula has been applied only to part of the budget, which is the health basket, which is primarily supporting district level operational health expenditures, is that you can do so much with a formula, but with a health system that is very fragmented in terms of its financing, those equity gains are going to be limited. And because, as we all know, the issue of resource allocation is inherently political as well as a question of economics or ethics, until we get better buy-in, I think, from politicians about the need to support the poorest areas and the poorest individuals, and we look more at the political economy of some of these issues, then we're going to have limited impact. And I think one way of, as we increase pooling and can apply such formulae to a bigger pool of the funds that are going into health systems, that will also hopefully have a bigger impact on the equity of existing spending. But I think one of the main things that we need to be doing is, again, as has already been said, stepping up our resource tracking, showing where the money is going, showing the impact, but communicating it in a readily understandable way, and showing the potential benefit that we could get from a more equitable allocation of the scarce resources. Thank you.
Thank you, Sally. Really interesting, good points. Ask any of not only the speakers, but anyone on the call if have any further reflections or thoughts on those points. It struck me when you were speaking, Sally, that the adverse consequences of fragmented funding, health financing, are many, and maybe those who are responsible for health financing being fragmented and maybe not as fully aware as they should be of some of the consequences for supporting efficiency and equity of health system design and allocation. And maybe it's some of those of us on this call and people like us working within our area who can try to do more to highlight that. But thanks, really interesting, thought-provoking points. Do we have any further thoughts, questions, or reflections? So if not, let's finish there. It's really fantastic presentations. Thanks so much to our two speakers, Joseph Mafuto-Benga and Edward Katika, and all of participants for joining the webinar. Just I'd like to highlight that the webinar was recorded and will be uploaded to the Global Health Economics Hub in due course, so you can access the webinar and also previous webinars from the series on that. This is actually the final webinar of the current series, but a new series which should hopefully beginning soon, and we'll be in communication about talks and topics for that series. If you have thoughts or would like to discuss, would like to present as part of the webinar series, please contact Edward, myself, or Steph Richards, and we can try to plan the next series. So it covers new topics and really has a wide range of speakers. So thank you for your attention today. I look forward to speaking again soon. Thank you all.